Hey guys, it's Joseph Farahani here with Prep for Step, and today's lecture will be about platelets, thrombogenesis, and platelet disorders. We will start off our topic with platelets, platelet granules, and platelet surface receptors. We'll then move into endothelial pro and anticoagulation factors. We'll continue our discussion with mechanism of primary hemostasis or platelet plug formation. We will also discuss platelet-to-platelet adhesion. We will briefly go into the drugs affecting thrombogenesis, and lastly, we will discuss platelet disorders. Okay, so here we have just a normal platelet. Now, platelets are cells in our blood that help stop bleeding, and they do that by forming a clot and a platelet clot. All right, so they are basically just fragments of cytoplasm from their parent cell, which is called megakaryocytes. They do not have a nucleus. And they contain different types of granules. Some are called dense granules, and some are called alpha granules. The dense granules are also called delta granules. Now, there's several of these, but for our purpose today, in our discussion today, I'm only going to mention a couple, and that is adenosine diphosphate and calcium. Again, there are several of them, such as histamine, serotonin, ATP. These are all dense granules, but we don't really need to know about those right now. Alpha granules are composed of basically von Willebrand factor, fibrinogen. Again, there are several other alpha granules such as platelet-derived growth factor, tissue growth factor beta, insulin-like growth factor 1, and something called platelet factor 4. But again, these are beyond the scope of our discussion today. So there's one other thing that you need to know, and that is that they produce something called a pro-aggregation factor, or thromboxane A2. And the way they do that is, kind of cool to understand the mechanism of it, and that goes by phospholipase A2 cleaving a phospholipid membrane at a particular site. Now, this is a membrane phospholipid. This would be our phosphate group, or the head, and these would be, the R1 and R2 would be two lipids, okay? Which is basically making the structure of a phospholipid. Now, there are certain enzymes that cleave the phospholipids at very particular sites, and those are called phospholipases, okay? For instance, phospholipase A1 will cleave a phospholipid right here. Phospholipase A2 would cleave a phospholipid right here. Phospholipase C would be here, and phospholipase D would actually be here. Now, phospholipase A2, which is the thing we're discussing today, is actually found in bee and snake venom, and they immobilize their prey by causing lysis in the phospholipid of the membranes. Now, phospholipase A2 will cleave the phospholipid, or the membrane phospholipid right here, and in a lot of phospholipids in the membrane, the R2 is actually, the fatty acid of R2 is actually a arachidonic acid, which is a 20 carbon fatty acid, okay? So basically, the phospholipase A2 will cleave a membrane fatty acid, giving off arachidonic acid, and then arachidonic acid is converted to thromboxane A2 by an enzyme called cyclooxygenase. And then thromboxane A2 is released and causes vasoconstriction and platelet aggregation. Now, there are several types of receptors that you need to be familiar as far as platelets are concerned, and those are GP. On these, GP just means glycoprotein, so glycoprotein 2B, 3A, glycoprotein 1B, and ADP. And this ADP receptor is basically a receptor for the ADP granule that is released from the platelet itself. The GP1B, it binds to von Willebrand's factor, and GP2B3A binds to fibrinogen and helps creating a bond between two separate platelets. There are also several intraendothelial factors that help with the process, or sometimes are against the process of thrombogenesis. One of those is von Willebrand factor, and it's released from endothelial cells. It allows the platelets to bind to the subendothelial collagen. TPA, or tissue plasminogen activator, is just a serine protease, and it converts plasminogen to plasmin, allowing for the coagulation to take place. Prostaglandin I2, which is basically a vasodilator. It counters thromboxane A2, so it blocks platelet aggregation, and it also counters the platelet-derived growth factor, so it stops the adhesion of platelets to endothelial cells. Nitric oxide and bradykinin together are just vasodilators, and always remember that vasodilators are always antithrombotic and vasoconstrictors are always prothrombotic. So now let's discuss thrombogenesis or platelet plug formation, okay? Initially, there has to be some endothelial damage. This, as you can see, these are endothelial cells down here, and these, their walls have been damaged. Once that happens, they will release their von Willebrand factor, and the von Willebrand factor, which is this guy right here, will bind to the subendothelial collagen, and then platelets that are coming by will actually use their glycoprotein 1b to bind to the von Willebrand factor. When that happens, they will release their dense and alpha granules. The dense granules are calcium for one of them, and the calcium will actually help activate all the coagulation cascade and allow the activation of all the coagulation factors. The next would be the ADP, or the adenosine diphosphate. It also helps platelets to bind to the endothelial cartilage. Another thing that it does is it actually sits on its own receptor, which is the ADP receptor, and it causes a conformational change in the GP, the glycoprotein 2b3a, and its expression on the cell surface or the platelet surface. Once this happens, more and more and more of ADP, the glycoprotein 2b3a receptors are going to be on top of the platelets. And as we know, the other alpha granules, one of the thing is fibrinogen, which is also released. And fibrinogen, with the help of glycoprotein 2b3a, is going to allow two platelets to actually attach together. Now, there are a few drugs that are actually pretty important to know, and their mechanism of action. And one of those is actually aspirin. Now, aspirin, which is taken a lot of times by people that have coronary artery disease, or if they've had angioplasty done or heart valve replacement, they take the baby aspirin or the 81 milligram aspirin per day just to block the production of thromboxane A2, because aspirin irreversibly blocks cyclooxygenase, therefore inhibiting the production of thromboxane A2, which is a pro-platelet aggregation. Now, the next one that you need to know is apixaban. Okay, apixaban is a monoclonal antibody, as the name suggests, and it basically blocks the GP2B3A. Okay, so it's a monoclonal antibody that is produced, and it blocks the GP2B3A, thereby inhibiting the cross-linking between two different platelets. The ADP receptor, this guy right here, is also blocked by two drugs. One is clopidogrel, and clopidogrel is the brand name for it is Plavix. The other one that is actually important is ticlopidine, or Ticlid, and that actually blocks this guy too, and they both of them irreversibly block the ADP receptor, and thereby inhibiting the GP2B3A conformational change and the expression of that particular receptor on the platelets. Moving on to platelet disorders. All of platelet disorders have an increase in bleeding time, and their problem is a defect in the platelet plug formation. Okay, patients typically present with microhemorrhage or superficial or mucosal bleeding, such as epistaxis or nosebleeds. They also present sometimes with petechiae or purpura, which are bleeding, superficial bleeding underneath the skin, and all of them will have an increase in bleeding time. But the platelet count in some could be more, and some could be decreased. Okay, so the first disease that we're going to, or the first disorder that we're going to talk about is Bernard-Soulier syndrome, and the idea is that in Bernard-Soulier syndrome, the glycoprotein 1b is deficient. If that is the case, then the platelets cannot attach to the von Willebrand factor, therefore increasing the bleeding time and lowering the platelet count. So platelet count will be low, but bleeding time would be increased. So the next disorder is Glanzmann's thrombasthenia, and asthenia just means that weakened. Okay, so it's the thrombosis that is weakened. Now, the problem with these guys is that they have a deficiency in the glycoprotein 2b3a. Therefore, there is a defect in the platelet-to-platelet aggregation. But since it's only a weakening of the thrombotic process, the PC, or the platelet count, will be normal. There will be no change in that, But the bleeding time, just like all the other superficial bleeding problems or the platelet disorders, will be increased. Okay, on labs, if you do a peripheral smear, you'll see that there's no platelet clumping, and the reason for that is because these guys cannot actually attach to each other. Therefore, there will be no clumping of the platelets. So the next disease we're going to discuss is called idiopathic thrombocytopenic purpura. As the name suggests, there's going to be thrombocytopenia, meaning there's going to be low platelet count. And the bleeding time, obviously, just like other platelet disorders, will be increased. The problem with these patients is that they produce, for some reason, which is idiopathic, we don't know why, they're producing antibodies against, they're going to produce antibody against the glycoprotein 2B3A. When that happens, the antibody platelet complex, as it goes through the spleen, the macrophages in the spleen will eat it up. Therefore, it will cause a platelet count to be low. And on labs, if you check the megakaryocytes will actually increase because they're trying to replace the lost platelets. So the last disorder that we're going to discuss today is called thrombotic thrombocytopenic purpura. Okay, thrombocytopenia, lower platelet count. Thrombotic, there's going to be thrombus, and purpura, there is superficial bleeding. So the bleeding time, the platelet count will be decreased. The bleeding time will be increased, just like other platelet disorders. The problem with these patients is that they have a deficiency in a protein called ADAMTS13, which is a metalloprotease enzyme that usually breaks down von Willebrand factor. If von Willebrand factor is not broken down, then the blood will contain multimers of von Willebrand factor, which you know that as our previous discussion, we said that glycoprotein 1b is used by platelets to bind to von Willebrand factor, and that will lead to thrombus formation. The patients typically present with thrombocytopenia, as we said. They might have neurological symptoms, and that is because the thrombi could break off and go up into the brain and cause TIAs or transient ischemic attacks and focal neurological symptoms. The patients could have renal symptoms because of thrombus formation in the renal arteries. They also have something called microangiopathic hemolytic anemia, and microangiopathic hemolytic anemia means we're breaking down where hemolysis is happening in these small arteries. And because of that, you're going to see two things because of hemolysis happening. One is an increased LDH, which is an enzyme inside the RBCs. As we fragment the RBCs, the enzyme inside them will leak out into the blood and will be increased in the blood. There's also going to be, on a peripheral smear, you're going to see increase in schistocytes, and schistocytes are nothing but fragmented RBCs because we just broke them down. And that basically concludes our discussion on platelet disorders and the primary platelet plug formation. Hope you enjoyed the video. Please do subscribe, like, share. You can hit up us on Twitter, and you can also see our Facebook page. Thank you very much, and see you guys next time.